overview and a good introduction to the subject. So I'll now move to the next set of tumors, that will be the pigmented tumors. Why are we not getting this? Okay. So talking about melanocytic tumors of conjunctiva next. So what happens basically is that if you look at the histopathology of a normal conjunctiva, so you see these epithelial cells, and this is near the basal layer of these epithelial cells. This is where the pigmented cells lie. And so all these problems related to pigmented lesions of the conjunctiva either are arising because of some proliferation of the pigments in this layer, or because of the melanocytes taking on a more notorious route. So commonly what we see are as pigmented lesions of conjunctiva can be classified as one of these four lesions. Either it can be a nevus or a complexion associated melanosis, a PAM or a melanoma. Let's see how each of them looks like through some of those clinical examples. So this patient comes with a bilateral symmetric diffuse pigmentation, irregular in the interpalpebral area, and it's referred to you for opinion as to rule out a malignancy because the pigmentation looks really dense and scary at times. But if you look carefully, these are both eyes of the patient. The pigmentation is very symmetrical on both sides. It's confined to the interpalpebral area, the fornices being clear. And you look at the general complexion of the patient, look at the face, and if it's a pigmented skin, then many a times these patients can also have increased pigmentation in the conjunctiva as well. So this is nothing to worry about. It's just a case of a complexion associated melanosis, and you can reassure the patient. Next is a 6-year-old child brought by parents worrying about this pigmented patch on the surface of their child's eye, and they see some reddishness growing along, and the referring doctor also feels concerned because he feels that there is some prominent blood vessel which is like a feeder vessel going inside. What is to be done? So nothing is to be done. You just reassure the parents and the referring doctor because this is just a congenital nevus. And so what happens is that basically these lesions are mostly congenital. The pigmented cells are very small at birth, but as a child grows, they also keep growing, and at times of puberty, at times of pregnancy, and sometimes even with prolonged sun exposure, these lesions can increase in size. So how you can be reasonably sure that this is not a malignancy is if you can identify these small cysts within the lesion. Now if you look under the slit lamp, you will see that these are clear fluid filled cysts in the substance of the lesion. And so once you see these cysts, then you can be reasonably reassured that what you're dealing with is a benign lesion and it's not something to do with a malignancy. Although there can be lesions where the lesion, the nevus can evolve into a melanoma, and you may have some area where it's a pigment, it's a nevus kind of thing, and another area which is looking more notorious. But those are fortunately very rare. 99% of the times what you will see will be with the cyst will be a nevus. If you sometimes have difficulty in identifying nevus, you see the cysts on the surface, but you're not really sure, or the parents are a little apprehensive, you want to show the parents as to what it is, you can do an OCT, anterior segment OCT, and that's where you will see these clear cysts clearly, and you can document these for your own purpose, academic purpose. You can show it to the parents and everybody can feel reassured. Sometimes young boys with VKC or allergy, they will present and the parents will say that this spot was there but suddenly it has become more red. You're concerned and they say that it's becoming and the parents are very apprehensive, so please take it out, please take it out. You take it out, and then when you send it to a pathologist, the pathologist reports it's an inflamed nevus. So nevi can get inflamed, especially in children who are prone to allergies and VKC and things like that. And you give a short course of topical steroids, the redness is likely to settle down, and then further on you can just keep on observing them or manage them, as will be discussed in the next lecture. So these are some of the typical locations where if you see a pigmented patch with microcysts, it's more likely to be a nevus. It's in the interpalpebral fissure near the limbus, the plica, or the caruncle. So these are the sites which are most commonly associated with a nevus. As Dr. Fairuz showed, sometimes you do get patients who are very fair skinned, or some patients traveling from abroad and they are little concerned about the lesion on their eye, and it looks more reddish, and if you would to do a biopsy on them, you would find that it's an amelanotic nevus. how you find out is that this lesion again will have a clear cysts, which are unfortunately not very clear in this picture. So these nevi have a less than 1% risk of malignant conversion, but you should be aware of that possibility also. And when do you look for, or when do you think about a malignant transformation is if a patient is presenting with a pigmented nevus onset in adulthood, if there has been a recent growth or color change in an adult who has always had a nevus, and if it's a location other than bulbar conjunctiva, plica or caruncle as showed earlier, if there are very prominent feeder vessels, very angry looking vessels, not like those tiny feeble kind of vessels that I just showed, melanoma will have different kind of more angry looking feeder vessels. And if you've excised one nevus and again it recurs with more pigmentation and some vascularity, it's a recurrence, then also you should suspect that. Now there are some systemic association, Carney complex and dysplastic nevus syndrome. Basically in dysplastic nevus syndrome, the patient will have nevi all over the body in different parts, and these are patients who are more prone to have melanomas also. Another commonly associated pigmented lesion that comes and presents in our OPD, I am sure all of you would have seen it at some point of time, and it's a diffuse, irregular kind of pigmentation on the surface of the eye. If you make a fine slit and look at this lesion, you will find that the lesion is not conjunctival, it's rather subconjunctival, and you can take a swab stick, as Dr. Fairuz again showed, you move the conjunctiva over it and the conjunctiva will be free. This is basically episcleral or scleral pigmentation, which because of its level, because of its depth, appears slightly gray or bluish. And this is not a melanoma or the nevus, this is melanocytosis. That's a term which is used for such lesions. The importance is that they can be associated with involvement of skin as well, which is when it's called as oculodermal melanocytosis. And if you have a patient of oculodermal melanocytosis, always dilate the pupil and look inside. Few of them, although rarely, can have a choroidal or uveal melanoma as well. Also, if you ask them to open their mouths, they may have pigmentation of the soft palate as well, which may be associated with esophageal carcinoma as well. And also look at their hairline. If they have some pigmentation on the hairline, then they can also have a meningeal melanomas. So these patients where you have these kind of pigmentation, also refer them to an appropriate specialist for cross-referral to rule out other systemic complications. Then another patient who presents with a recent onset diffuse pigmentation, ill-defined pigmentation. Now this is conjunctival pigmentation, very ill-defined, very irregular, and the patient gives history that he's been having this for the last 6 months only, and it's been sometimes growing and sometimes it looks like it's settled down. So what this is basically what is called as primary acquired melanosis or CMIN, that's conjunctival melanoma in situ. So this is basically a superficial kind of pigmentation in the epithelial layers, and it's, as the name suggests, it's acquired, it's primary, it's mostly seen in middle-aged people, and you may get a history that it's increasing or decreasing in size and level. Now these are the various patterns. Sometimes you see different patterns of this PAM, and if you are concerned, or if the lesion is large enough, then you may do a biopsy for these lesions. And then what is important is that the pathologist should be able to tell you whether this PAM is PAM without atypia or it is PAM with atypia, because both these things will have a different prognostic value for the patient. So if it's PAM without atypia, then there is no risk for development of melanoma. Then if it is a PAM with atypia that comes out in your histopathology, if the pathologist doesn't mention, and it just mentioned, the report mentions it is just PAM, you have to call up the pathologist and ask whether it's PAM with or without atypia. That's your job to ask them. If it's PAM with atypia, then there is approximately 46% chance of conjunctival melanoma. That's nearly 50%. So these are the patients where you need to be a little more aggressive in your treatment. And then there are other factors. If the atypical melanocytes are in the epithelium, which are located in other than basal layer, then it's almost 90%. So basically these are different factors by which pathologically, with pathological reporting, you can actually correlate the risk of development towards a melanoma and take appropriate action. Now sometimes a patient will come, an old patient, elderly patient on anti-glaucoma medications for a long time will present with a small line of pigmentation in the fornix. So don't worry about that. Keep the patient under observation. This can be because of the medication only. And if you change the medication, this sometimes can go away. And then other causes of pigmentation like Addison's disease also can cause a secondary acquired melanosis. So you need to differentiate between primary and secondary at times. And at times there is no harm in doing a biopsy if you have any doubts. So moving on to the most notorious type of pigmented lesion on the surface, that's the conjunctival melanoma. And most of these, almost 75% of these are associated with primary acquired melanosis with atypia. And rarely 20% may be associated or develop from a nevus, and very few of them arise without any of these pre-existing lesions. So although there can be some risk factors like dysplastic nevus syndrome or neurofibroma or xeroderma, as Fairuz mentioned for OSSN, these patients can also have xeroderma, patients can also have more of a melanomas. Now this patient presented with a pigmented mass, large nodular pigmented mass in the fornix, very deeply pigmented here, slightly less pigmentation here, more reddish thing. So this was a case, which probably had at some point of time some PAM, which was ignored, and that eventually developed into a melanoma. Another similar patient, I remember this patient, he was a doctor himself, and he had pigmentation for a long time, never bothered about it. And then one fine day, he comes that he's been seeing this nodule in the eye, and with deep dark pigmentation spilling over to the skin, and a large nodule which is lying in the fornix. You see all this pigmentation on this lid margin as well, on the surface of the lesion as well. This again is nothing but a melanoma. So what you have to do at this stage when the patient comes, it's already gone way beyond local resection, and we'll talk about management in the subsequent parts. Another patient you see with the diffuse deep pigmentation of the fornices spilling over to the lid margin, and also presence of these nodular thickening over the caruncle. It's kind of very thick nodule, very darkly pigmented. Again, you take a biopsy, and this was a melanoma again. So some of these cases which presented with PAM with atypia, as mentioned, most commonly that is the one which develops into melanoma. So you have to be really careful when you are seeing a patient of PAM with atypia. When to intervene, where to intervene will be discussed in the subsequent lecture. And these are really bad tumors, melanomas. There's a high risk of metastasis. This is Western literature, up to 9 to 25%. I'm sure in Indian subset we'll have even more higher risk of a higher proportion of metastasis and patients dying of these tumors. These are the common sites where they can go: lung, liver, GI. And also now we have a AJCC classification, proper AJCC classification, which is available for any systemic cancer. We also have that for melanoma. People who are interested in academic pursuits may go through this AJCC classification when they see a patient of melanoma. Mortality is also high. It's nearly 40% mortality at 10 years, 40 to 50% actually it is. So that's quite bad. And sometimes you have patients being referred to as melanomas, but when you have a close look at them, you see that this is like a lesion which has got some keratin on the surface, which has got some feeder vessels and some intra-lesional vasculature also. So with the presence of keratin, and you see keratin here and keratin here, so this was basically OSSN, as Dr. Fairuz showed in the previous lecture. And basically in Indian patients, at times we do get pigmentation on the surface. And again, another patient who may be referred to as a melanoma, but if you do a B scan and you look closely at this patient, this is nothing but a staphyloma, ciliary staphyloma. A young patient was referred for diffuse pigmentation of the conjunctiva here on the right side, and then you have to also ask proper history. So now this patient gave history of a VIA surgery done previously. So sometimes you may have a situation where the choroidal pigment leaches out through the port of VIA surgery, and that can also deposit in subconjunctival space. And the surgeon got worried whether he has intervened in a patient who already had a melanoma or something like that. So nothing like that. This can also happen from a wound leak. So this pigmentation could be easily washed off and the port closed with another suture. The patient was doing fine. So briefly mentioning the stromal tumors. Stromal tumors are relatively less common than the epithelial tumors. So some of the tumors that Dr. Fairuz showed were also part of stromal tumors. Now this patient, a 40-year-old male, presented with this kind of a smooth reddish mass near the limbus and was referred as OSSN. But what will you notice here is that it's the odd thing about this lesion was it's relatively smooth, shiny. There was no keratin on the surface. There was no intrinsic. There were some vessels intrinsically growing inside. So my thought was probably it's a atypical kind of OSSN which does not have a keratin, or thought it's a localized form of a lymphoma. But anyhow, the treatment was biopsy, and to my surprise, what it turned out to be a neurofibroma. So neurofibromas are stromal tumors which are relatively rare, and but they can mimic or masquerade an OSSN, or sometimes if it's a smaller one, you may think it's a nodular inflammation of the surface which does not respond to topical steroids or the conventional treatment for episcleritis. So one can keep in mind the rare possibilities also, and ultimately the biopsy helps in the final diagnosis. Then we have lymphoproliferative lesions of the conjunctiva, and these lesions can be benign. Like this was a young child presented with a pinkish mass, but you have to rule out a lymphoma. So you do a biopsy, it turned out to be a benign reactive lymphoidhyperplasia, and this is the malignant form, lymphoma. So especially if these lymphoma patients have a bilateral lesion, they have more chance of developing a systemic lymphoma as well. So you need to keep those things in mind, and also take into consultation a medical oncologist if you're dealing with a bilateral lesion. Mostly these patients will also have an orbital component, so you do a proper imaging and treat accordingly if it's a localized or a systemic lymphoma. Another entity which is recently described entity is conjunctival stromal tumor. So basically we know stromal tumors are like maybe neural tumors, maybe lymphoproliferative tumors or vascular tumors, but there is a set of tumors which does not fit into any of those categories. Basically histologically these lesions have spindle cells with a lot of myxoid stroma, and when you send them for a biopsy, they are benign tumors, but the important thing is that you need to differentiate them from myxomas, which may have a systemic association in form of atrial myxomas. So that's why pathology is important. You need to rule out a myxoma. Okay? If it's just a simple stromal tumor and not a myxoma, which can be differentiated with IHC and with pathology, proper pathology, then there is no further intervention required. So some vascular tumors, Dr. Fairuz showed pyogenic granuloma. Some other vascular tumors, this is like a varix, and this is a venolymphatic malformation. Basically, these are mostly extensions of the orbital components which protrude anteriorly. So I conclude here. Thank you very much. I hope I didn't extend from my time.